some differences like cementum like thing will be there, and it is going to show a formation of cementum like tissues that is going to be in the cementoblastic stage. In this stage, you won't see a lytic lesion, also a radio opaque lesion. It is going to be a mixed lesion. And the third is the maturative stage, wherein the lesion is going to show a complete radiolucent, radio opaque lesion around the tooth which is affected. Okay, so these three stages are very important in this particular topic. So periapical, okay, these are going to be seen in the anterior tooth. Okay, anterior tooth most commonly will show this three stages which I said earlier: radiolucent stage, a mixed stage, and a matured stage. Okay, radiolucent, it is going to be radiolucent in nature. Then it's going to show a mixed lesion where you cannot define whether it is radiolucent or radioopaque. Then it is going to be a mature radioopaque lesion. Okay, it's going to be seen in the anterior tooth. Okay, the last is going to be the florid. It is going to be multiple lesions present in throughout the jaw region. Okay, so it's going to be seen in the mandibular region. So this particular lesion is very common in the African population. Okay, that you have to remember. African female patients are more commonly affected with this particular condition. So this is a tooth which is showing changes, and this is the histopathological change. Okay, cementum like material is usually seen in the histopathological lesion. So moving on to the next big topic, blood disorders. Okay, blood disorders is basically very important because it is going to overlap with the general medicine as well as oral medicine topics. Okay, blood disorders, mostly we will be concentrating on anemias. Okay, because anemia is a very important topic, because anything related to the blood dyscariasis, like what is the normal range and how the patient is to be treated, and what is the features clinically, histopathologically, and what is the important feature that has to be seen for identifying this particular condition, what is the reference range, everything is going to be a 1 mark question. Okay, so you have to keenly study every range for the disease condition, and also other than anemia, you should also concentrate a little more on WBC disorders, because WBC disorders like leukemia, lymphoma also is very important. Okay, so I have displayed the normal hemoglobin value for the females, males, and the newborn. So you must be knowing all this, but still you should know the exact range, okay, in order to answer the most right answer in the given option. Okay, so for the females, it's going to be 12 to 15. So for the males, it's going to be little higher, 13 to 17, and for the newborn, it's going to be even more higher, because in the newborn stage, the patient is going to have a increased hemoglobin value. Okay, so all these has to be highlighted. So the pathophysiology here is basically there is an increased need for the blood. Okay, but there is so what is the pathophysiology behind anemia as such? There is an increased need, but the amount of that the body is producing is not enough to meet that need. So that in that case, you will develop anemia. Okay, so body's need is more, but it is not able to produce the amount that is needed by the body. Okay, so in that case, you will develop a deficiency, and you will develop anemia. Okay, so anemia, basically you can classify it into two types. Okay, pathophysiologically, how pathologically it is appearing, and depending upon the morphology of the cell, you can classify them. Okay, so this is a classification. Okay, it's very important to know the different classification under which you can classify anemia. Anemia because of the hemorrhagic condition, that is due to increased blood loss. That is going to be an acute condition. It's not developed for a longer time. It's just happened because of the acute blood loss. The patient is experiencing anemia, and also because of some chronic blood loss like GI disorder, wherein the patient is having a chronic bleed, or some hormonal changes, or something related to your normal hormonal changes, you will have a chronic blood loss. In that condition also, even when the patient is hemorrhagic also, they will develop some acute they will develop some form of blood loss. Because of the blood loss, the patient is going to be anemic. Other than that, they will not have any other problem, okay, as such. Anemia is due to impaired red cell production. That is because of the deficiency, something that is important for the production of the iron cells, or something that is important for production of hemoglobin itself is defective. Then you develop something called as deficient type of anemias. This could be deficient hemoglobin, or deficient iron, or deficient globin synthesis, or heme synthesis. Okay, in that condition you will experience iron deficiency anemia and thalassemia. Then coming to the maturation defect, that is folic acid, vitamin B12 deficiency, all these is going to lead to the megaloblastic anemia. Okay, so then anemia due to some bone marrow infiltration or some inborn defects in the extrinsic factor, all these are going to be resulting in anemia. Okay, so morphological, these are the pathological causes for the anemia. Okay, what is going to be the morphological causes? That is, the anemia can be morphologically classified into, so pathologically you can see all these pathological conditions, but morphologically you can just say whether the cell is smaller, and only because of the size of the cell and the color of the cell. If it is going to be a smaller sized cell, it is going to be microcytic, and if the color, that is the chroma, is below normal, then you say it is as a hypochromic. And normocytic, normochromic. Okay, it is going to have a normal size and normal chroma, but still it is going to be defective. And then the macrocytic, normochromic, that is the size of the cell is bigger, but it is still having its normal color. Okay, so these are the two different anemias. Okay, so moving on to the clinical features. Okay, moving on to the clinical features, you can expect speed of onset of the anemia, severity of the anemia, age of the patient, and hemoglobin dissociation curve can also help in identifying the features of the patient. And symptoms, as we all know, the patient will always have fatigue, okay, and muscular weakness. They will feel more lethargic, and headache is usually seen. In older patients, you can expect angina and claudication, confusion, and disturbances. Okay. And basically the signs and symptoms, you can expect palpitation and easy fatigability. So all the other symptoms like tachycardia, collapsing pulse, faintness, retinal hemorrhage, mild proteinuria, menstrual disturbances, and anorexia is also usually seen. So investigation of anemia, how can you investigate anemia is very important. Okay, hemoglobin examination is the one standard thing that you can identify with the help of the hemoglobin production. Okay, if the hemoglobin is defective, then you can expect to have, okay, you can expect to have an deficiency in the hemoglobin. And peripheral blood examination can give you an idea of how the cell is present, whether it is small or whether it is big, or whether it is larger in size, or the color is defective. All this can be examined with the help of peripheral blood smear. Then red cell indices, okay, the packed cell volume, everything can help in identifying the anemia. Then leukocyte and platelet count, okay, you can compare with that of the red cell, and you can come to a conclusion whether it is more in number or less in number. Then reticulocyte count, that is the before the RBCs could develop, it has this reticulocyte. Okay, the reticulocytes are immature RBC, so these reticulocyte count can also taken as an investigation. Okay, then ESR and bone marrow examination. Bone marrow examination will give a complete picture of WBCs and red blood cells together. Okay, in order you can find the defect in that. Okay, so hemoglobin estimation, the peripheral blood smear. So these are the examples. Okay, anisocytosis, there is a cell size variation is there. Usually it has to be a biconcave, okay, type of cell. Whenever there is a size, smaller size or a bigger size, and it is not actually spherical in shape, then you call it as anisocytosis. Then the nucleus, if it shows some changes, and if there is a hypochromasia, that is, it is more having more chroma or less chroma, or some basophilic stippling, or Havel-Joly bodies are nothing but Havel-Joly bodies. These are some blue color pigmented appearance that is seen in the RBCs in the anemic conditions. Okay, so these are the features with which you can find anemia in the blood smear. Okay, so it's a very important topic. You can find all these, okay, in the anemic patient. Not that you should find everything, but some changes will surely be there if the patient is severely anemic. Okay, so these are the other changes. Okay, you can find this this image is from Hashmon. You can always see this image. So all the different, other than, so this shows the different morphological shapes and sizes of the changes. Okay, and which condition you can find all these type of changes, it is very important. Okay, sickle cell anemia, you can see a sickle shaped cell, and also cystocyte, and where all these are present is very important, and what are the changes that you can expect in the RBCs. Okay. So moving on to iron overloading can also cause some conditions like this: bronze diabetes and cirrhosis. So iron deficiency anemia. So we have just seen in general. So why iron deficiency anemia? So if there is an reduced amount of iron that you are taking, or there is an improper absorption, you will finally end up in the iron deficiency anemia. Whenever you are the intake of iron is very much less, okay, for less than 1 mg, then you're going to experience iron deficiency anemia. Or if the intake is proper but the absorption is defective, then also you can expect to have iron deficiency anemia. Okay, so that's what I've told. Where it is absorbed in the duodenum and the proximal jejunum is also very important. Okay, whenever the absorption is improper in these areas, then you can expect to have iron deficiency anemia. Okay, so pathophysiology, if there is no iron intake, the tissues are the production of the hemoglobin is going to be improper, and tissue will go on exhaustion of the, so all the storage iron, the iron in the form of ferritin will be stored in the body, but this is going to be exhausted. Okay, when there is no enough iron that is needed for the production of hemoglobin. So in that case, we would experience iron deficiency anemia. Okay, so clinical features, it can be a proper anemia, which we saw till now. The clinical feature would be like this, or it can be some epithelial changes alone. Okay, so anemic changes we have discussed already. So all these are nail changes, atrophic glossitis, angular cheilitis is an important, atrophic glossitis and angular cheilitis is an important oral findings for anemia. Okay, we can easily find out the patient is anemic just by seeing their oral cavity. Then Palmer-Wilson syndrome, these are nothing but formation of webs in the esophagus, which is going to disturb the patient from having a normal healthy diet. Okay, oral manifestation, as I said earlier. Then hemoglobin, so the similar RBC indices can also be followed for this iron deficiency anemia. Then biochemical findings, you can see a low level of iron. Okay, and the total iron binding capacity will be less. Total serum ferritin level will also be less. That is, the storage is also less, because the patient is now exhausted. Okay, with the amount of iron which is present, all the storage iron has also been now used up. So in that condition, you will have very less amount of stored iron. Okay, so these are the differences, how a normal red cell would appear and how a microcytic anemia patient would have a red blood cell, and normoblastic cell how it is usually, and now how it is microblastic. So normal, how much cells will be there, and there is some deficiency here because the production itself is defective. Okay, treatment, correction of the disorder and correction of oral iron deficiency with the help of oral supplement and parenteral therapy in case of severely ill patients. Okay, so this is a chart which shows why Plummer-Wilson syndrome is very important. Because of iron deficiency anemia, the patient is going to develop esophageal web, and this web will obviously lead into dysphagia. Patient is unable to swallow anything. Okay, in that case, so it is very important to treat it at earliest. So if you correct the iron deficiency, it is obviously going to correct these conditions. Okay, when in severe patients, we need to have some other surgical treatment included in this therapy. Okay, women are more commonly affected, and 40 to 70 years of patient is more commonly affected. So you can always go with the you can always go with an endoscopy to identify the condition, then treat with the iron supplements and also with some surgical procedures. Okay. So moving on to the skin, diseases of skin. So before we go into the diseases of skin, I hope everybody is clear with the blood disorders, because blood disorder is very important topic. You can expect more questions out of this. Okay. So also you have to go in and check out on things of WBC disorders, because leukemia also holds equal weightage, because sometimes you can expect questions from acute myeloid leukemia, chronic myeloid leukemia, and what are the important cells and features which are present in these conditions. Okay, as I detailedly told everything for RBCs, the similar things has to be studied even for the WBC. Okay, WBC disorders are very few, but still you have to study the important features that is that can be asked in MCQ. Okay. So now we are going into the skin disorders. So in skin disorder, we will be discussing about Lichen Planus and Pemphigus Vulgaris. So these two are very important. Other than this, you should also be knowing about a few commonly occurring diseases like epidermolysis bullosa, all these things, because these skin lesions are even can even show oral manifestation. So any skin lesion with oral manifestation is going to be an important topic. So before we begin, okay, it's important to brush up all the things that we have seen earlier. Okay, we started with the infection, then we went on to finishing the blood disorders. Okay, so I hope till now it is very clear, because once you start learning about the skin disorders, so it's going to have a lot of features. So it's a variety of features that you will be seeing in the skin disorders. Okay, so I think we can keep going with this. So first, the agents which induce lichen planus and lichenoid reaction. Okay, so agents, basically the first thing is going to be some type of drugs. Okay, some very common ones is going to be the stress induced one. Okay, stress induced lichen planus is more commonly seen, and other than that you can also see drug induced, and some contact allergies also can cause lichen planus. Okay, so all the drugs, okay, I have listed everything. So all these drugs has to be marked up somehow, because the commonly causative agents is going to be an important MCQ. Okay, lichen planus and its causative agent is going to be an important MCQ. So all these has to be learned in order that you answer questions related to lichen planus. Okay. So moving on to the pathogenesis. Pathogenesis, basically it's an immune mediated response. That is it's an immune mediated response, and it is an autoimmune condition wherein the patient is going to develop auto antibodies against the patient's own cells. Okay, there is going to be some auto antibodies that are going to be formed against the host cell itself, mistaking that these have some problem and these are foreign to the body. Okay, so these are very important. Okay, these autoimmune related conditions are basically treated with steroids. Okay, there are no other treatment for these conditions. So what is the mechanism behind this? Basically, because of some irritation or some activation by the agent, the CD4 cells and other immune related cells are being activated. These activated immune cells thinks that there is some problem with the basal cells, that is the basal cells that are lining the epithelium. So they think that there is something some defect in the basal cell, and they go on attacking the basal cells. Once the basal cells are attacked, what happens? There is a disruption between the epithelium and the connective tissue. Okay, the connective tissue, epithelium and the connective tissue barrier is lost, and it is going to produce some disorder which will have a vesicle formation, which will later result in the lichen planus. Okay, So because of this barrier break, we are going to have some skin lesion. Okay, so basically this is basically this is because of the disruptions in the basal cells. Okay, so the basal cells are being identified as a foreign body, and it will cause apoptosis of the basal cells. So because of this, you find a typical lichen planus like lesion in the skin. Okay, so similar thing. Okay, here you see a basement membrane. Okay, this basement membrane is going to have a connection between these are the keratinocytes. It's going to have a connection between the epithelium and the connective tissue. These basal cells are being disrupted by the immune cell because of some reason, that is autoimmunity that is happening. The patient is going to have a break in the epithelium and the connective tissue barrier. Okay, so we have to know about the 9 P's of lichen planus. It could be an MCQ question. So the patient is going to have a papillosquamous disorder, pruritic lesion, polyangular, it can have any angle, plain top, it's not a raised lesion, it's a flat lesion, and it is pigmented, usually purple color pigmentation, and later it will go on to produce a black color lesion, and it is going to show papules or blocks. Okay. So these are the important clinical feature which you need to know. So patient is usually present with a oral lesion, skin lesion along with it. Okay, oral lesion is going to show some white lacy appearance called as Wickham's striae. Okay, so that is an identifying feature for the oral lichen planus, and in the skin lesion, it is going to usually be a purple color lesion, which will usually caused because of the apoptosis of the basal cells. So what are the types of lichen planus? Basically, it's a reticular, erosive, atrophic, flock, papular, and bullous lichen planus. So these are the types, and types is also very important actually. So moving on to Pemphigus vulgaris. Okay, Pemphigus vulgaris is also another skin-related condition wherein the keratinocytes will have a protein called as desmoglein. These desmoglein protein will hold the keratinocytes together. Okay, it helps in the adhesion of keratinocytes to each other. So these keratinocytes will take help from these desmoglein 1 and 3 to hold on to each other. Whenever there is a defect in these proteins, these desmoglein would be broken down, and the keratinocytes will become non-cohesive. Okay, because of this, the patient will develop blisters. Okay, so this cohesiveness of the keratinocytes is being lost because of the loss in the desmoglein protein. So desmoglein protein, how are they being lost? It is also an autoimmune condition wherein our own cells are producing antibodies to disrupt these desmoglein proteins. So the desmoglein 1 and 2 is obviously going to be disrupted because of these autoantibodies producing some suprabasilar defects. Okay, that is, it is above the basal layer. Before in lichen planus we saw it is at the basal layer. Okay, basal cells are being affected, but it is here happening in the keratinocytes that are above the basal cells. So the clefts are usually seen above the basal layer in the histopathological section. Okay, that I can explain by showing this image. Okay, this is the keratinocytes. Okay, basically keratinocytes are held together by the help of desmoglein 1 and 3. When these desmoglein are broken down by the autoimmune cells that are produced by the body, the cells become non-cohesive. Okay, so this is basically to explain the layers of the mucosa. Okay, you can see a keratin layer, and this is the layer I'm talking about. In case of lichen planus, it is going to happen in the basal cell. Okay, in between the basal cell and the connective tissue. But in case of pemphigus, it is going to happen in the spinous cell layer, where the cells are being held together with the help of desmoglein 1 and 3. So this difference is very important between lichen planus and Pemphigus vulgaris. Okay, so moving on to the salivary gland thing. Okay, so before we go into salivary gland disorder, so we will first brush through the skin lesions. Okay, because skin lesion is very important, because the differences in each skin lesion and what is their oral manifestation and how the mucosa is going to be present when they have these defects. Okay, that's very important. Okay, so the first thing is going to be the Pemphigus vulgaris, wherein we saw the lesion is going to present in the spinous cell layer before, that is suprabasilar clefts will be formed because of the non-cohesiveness of the keratinocytes. But in case of the Lichen planus, it is going to be between the basal cells and the connective tissue. That is, the basal cells become defective here, and the barrier between and the connection between the epithelium and the connective tissue is broken down. So you see clefts in the below the basal layer. That is, below the basal layer, you can see the cleft. Okay, for this Pemphigus is going to be suprabasal. For the Lichen planus, it is going to be below the basal layer. Okay, subbasilar layer. So that is the important difference that you need to know. Other than that, the clinical features of Lichen planus is very important, and how you differentiate that with that of the other white lesion is very important. Usually in the mucosal lesion, you can see some reticular types of Lichen planus which shows some webbing or white striations, or which is connected to each other, is very common. So with that, you can find some difference between other white lesions. Okay, whenever you think of a white lesion, you should think in terms of all this. But when it comes to Lichen planus, it was not only with the oral, it not only comes with the oral features, but it will surely show some skin features also. With the skin features and the oral features, we can combine to a conclusion of Lichen planus. Okay, I hope I'm clear with all this. Okay, next bigger topic is going to be salivary gland disorders. Okay. So basically, before we go into the pathology, we will see the general introduction to salivary gland. Okay, salivary gland is nothing but it is made up of mucus and serous gland. Okay, this salivary gland will have secretory duct. These secretory ducts will have different arrangements. Okay, and the different cells will line these secretory ducts. Okay, so whenever you have a salivary gland, it is a mixture of ducts, and these ducts will be made up of many cells, and mucous acini and serous acini are seen. So mucous acini will be made up of, okay, mucous cells, and serous acini will be made up of serous cells. Okay, that's the difference. Okay, so what is the reason behind knowing this normal anatomy is that mucous cells, when they become malignant, they give some form of give rise to some form of malignant tumors, and the serous cells will give rise to some form of malignant tumors. Other than this mucus and serous cells, you can also find something called as a myoepithelial cells. These are the cells which is placed around the acini like a basket shaped. Okay, or these are the small cells which have some contractile properties. That is, they will help the gland to secrete the mucus or the serous secretions into the duct. Okay, they have some contractile properties. That is, these are the muscle type of cell. Okay, this muscle type of cell is going to crush the salivary gland to produce their secretion into the glands. Okay, other than this, you have to know about the ducts. Okay, the intercalated ducts, thus that is, it is connection between two glands, and the striated ducts, it is the intercalated duct which go on to form a striated duct, and these striated duct will form the entire big excretory duct. Okay, from here intercalated duct, then it goes on to the striated duct, and these striated duct will form a main excretory duct through which you get the saliva out of the ducts. Okay, so you have to know about the mucous cells, then the serous cells, then the myoepithelial cells. So all these cells, okay, will give rise to a individual tumor. Okay, so when many tumor will have a predominant myoepithelial cell, predominant mucous cells, and predominant serous cells. Okay, so this is the concept. So histogenic concept just means that what are the cells will contribute to the main formation of the neoplasm itself. So telling about the origin, that is histological origin, the cells from which the tumor is going to develop is called as a histogenesis, and morphogenesis is what are the cells that together will form the morphology of the a structure, or the morphological structure of the tumor is going to be the morphological concept. Okay, so with this you should be knowing about few these are all a little higher end, but still you should be knowing about the concepts, okay, theories. So histogenic concept, from which cell, okay, the tumor is going to develop is very important. So it is going to develop from a basal cell, or it is going to develop from a pluripotent unicellular cell, semi-pluripotent bicellular recessive theory, or it can be a multicellular theory. That is, it can develop from any cell. Many cells can give rise to this particular tumor formation. Okay, so all these theories is very important. Similarly, which all the cells will contribute to the formation of the histogenic concept is basically from which cell the tumor is developing, and morphological concept is just that which all cell will contribute to the formation of the tumor is being explained by the morphological concept. Okay, so classification of salivary gland based on morphogenesis. Then these are the classification of the benign and malignant tumors. Okay, you have to look into the WHO classification for any lesion. So when it is concerned with the salivary gland also, you should first know about the recent WHO classification. Okay, so this is the recent classification wherein some entities have been added. So mucoepidermoid carcinoma, we will be seeing detail, and also gliomorphic adenoma, because these two are the most commonly seen structures, and the questions related to MEC and gliomorphic adenoma are more commonly asked than MCQs. Okay. So clinically, you can expect the patient to have a palatal swelling. Okay. It is going to be common in the 2nd and 8th decade of life, and it is going to be occurring in the major salivary gland. Most, that is 60% of them are going to occur in the major salivary glands, and a few will also occur in the minor salivary gland, even in the palatal region. Okay, so moving on to the next thing, which is the cells. Okay, so histopathologically, okay, for every salivary gland lesion, you should know what is the histopathological composition of these salivary gland tumors. Okay, here the cells are more commonly seen are the mucous cells. Okay, then the cells which have other features. Okay, so the mucous cells along with some cystic formation is also seen. So the first cells you should be knowing about in the mucoepidermoid carcinoma is going to be the mucous cells. Okay, these are the cells containing mucin, more in the minor salivary gland, and these are going to be large round oval cells. Okay, you just have to know these contain mucous cells. Okay, the next thing is going to be the intermediate cells. Okay, these are the cells which will give rise to some other cells also. Okay, they believe that these intermediate cell will give rise to the other cells in the tumor. So these are going to have a basaloid, that is, they appear like a basal cell, and they are going to be identified as a progenitor for two other cells, mainly the mucous cells and the epidermoid cell. Okay, these cells are called as intermediate cell. Okay, then it's going to be the epidermoid cell. Epidermoid cell is nothing but cells will appear like a squamoid or a polygonal or a shape polygonal shaped cells with keratinization. Okay, these sometimes even form something which is resembling to the keratin pulse, which will resemble a squamous cell carcinoma. Okay, then clear cells. Clear cells is also very predominant in the mucoepidermoid carcinoma. So all these cells from now we have saw mucous cells, mucous cells, intermediate cells, epidermoid cell, and clear cell. Okay, all these cells are very important to identify histopathologically the MEC. So also grading of MEC. Grading of MEC is very important in order to treat them accordingly. Okay, a low grade MEC will show mucous cell and intermediate cell, and they will show a lot of cyst-like formation. Okay, they will have cystic formation. Okay, many cysts will be formed. The cells ratio is going to be less. Okay, in that condition, you would grade them as a low grade mucoepidermoid carcinoma. Okay, then going on to intermediate intermediate grade. In this, the intermediate cells are going to predominate, and there is very less amount of cyst that is formed in comparison with that of the low grade. Okay. Then the high grade, here you are going to see more epidermoid cells, okay, and less amount of other cells, and the cystic cyst formation is completely low. Okay, there is going to be minimum, there are no cyst like formation, it is only loaded with malignant cells. Okay, so these are the examples of low grade, intermediate grade, and high grade squamous cell carcinomas. So what is an exfoliative cytology? So exfoliative cytology, you just take the secretions or the cells that are exfoliated from that region, and you see it under the microscope. So similarly, you do something called as FNAC. So for a salivary gland lesion, you need to identify a cell in a salivary gland tumor. You have to go in for a fine needle aspiration cytology. Fine needle aspiration cytology, you are going to draw the secretions from the tumor itself, and you see under the microscope. So this is going to give about 60% of the exact scenario that is present in the biopsy. Okay, it is a very important step before biopsy. You can find about almost most of the cell that is present in the salivary gland secretion can be identified with this, because all salivary gland tumors are going to have some secretions because they are having mucous and serous cells in them. So these secretions will have the cells that can be pathognomic for each tumor. Okay, these tumors can be identified with the help of FNAC. So FNAC is a very important investigation in case of salivary gland lesion. That can also be an important question. Okay, FNAC is very typical for a salivary gland lesion when it concerns to the investigation of tumor in the oral cavity. Okay, so these are the grading system. This is a modified Haley grading system. So this is just important to know, okay, what is the different classification or with different grading system that is being followed. Usually a number or a grade or a score is given depending upon the cyst that is present, depending upon the cells that predominate, depending upon the amount of cell, and what is the composition of the cell type. With all this, you can give the scoring or grading. Okay. So now we will see about gliomorphic adenoma. So gliomorphic adenoma is the next common salivary gland tumor, which is usually seen in the parotid major salivary gland. Okay, so gliomorphic adenoma is a mixed tumor. Okay, it's called by all the other names, and these gliomorphic adenoma basically is because of the mutation in the gene called as PLAG1 gene. Because of this mutation, the salivary glands will develop a benign tumor-like condition. Okay. So this is a pleomorphic adenoma. It's usually unilateral, okay, and it's usually seen even in the other sides of the other major salivary glands as well. Okay. Even the palatal region have also reported some pleomorphic adenoma, the minor salivary gland. Okay. So in this, as we saw earlier in the mucous cells and the intermediate and the epidermoid cell in the mucous MEC. Here we see in the pleomorphic adenoma, we see something as the ductal cell and the myoepithelial cell. Okay, the ductal cells are associated. These give rise to a couple of the tumor, constitute the tumor composition, and also the myoepithelial cells also contribute to the tumor formation, and these are appearing in a specific appearance. Okay, along with this, you also see some chondroid-like appearance, chondroid or myxoid-like appearance. Chondroid are nothing but the blue color tints that you see in the picture, and myxoid appearance, that is, it shows more connective tissue cells in that in this histopathological sections. Okay. Some plasmacytoid cells and spindle-shaped cells can also be seen, and myoepithelial cell with clear cytoplasm can also be seen. So these are the different histopathological presentation of pleomorphic adenoma. Okay. So they have recently reported few malignant cases of gliomorphic adenoma, that is carcinoma, ex-gliomorphic adenoma, or carcinosarcoma, or metastasizing mixed tumor. These are the some mixed tumor, malignant mixed tumor. So, and also they have been many reports saying that gliomorphic adenoma also shows some malignant transformation in later stage. Also, recurrence is also more common in this particular condition. So, for this, the two important entities we have seen in the salivary gland. So, it's not only that, we also have to concentrate on the other tumors. I've just highlighted on the commonly occurring salivary gland tumor. Okay, other than this, you can also have many major and minor salivary gland tumors. Okay, adenoid cystic carcinoma like things, and those the tumors which are common in the children is also very important. Okay, that has also been studied. Okay, so we now come to the final topic. Okay, before going into that, okay, we will have a small recap of what we have already seen till now. Okay. I just wanted to again emphasize on the infection part. Okay. Okay, before we go into the next topic, we saw about the bacterial infections. Okay, so infections, you have to like think in terms of, okay, in the bacterial infection, you don't see anything like a prodromal syndrome. That is, the patient will directly have the symptoms which is associated with the infections. But when you go on to the viral infections, the patient is obviously going to have some prodromal symptoms. Okay, why these prodromal symptoms? So any viral infection will first begin with the fever, okay, and tiredness, fatigue. Okay, since viral infection, why I'm again specifically emphasizing on that, because we have a pandemic going on, and you need to know everything about the COVID related symptoms. Okay, so any infection is first going to start with the prodromal symptoms like fever, fatigue, then myalgia, everything associated with a viral infection, and then the patient will start developing those infections which is related, which is very specific to that particular condition. Okay, viral infection. Okay, it's very important because COVID related symptoms. And now you have to know about the variants. Okay, I even saw some questions which asked what are the variants and what is the current investigation that you need to know, what is the rapid testing kit. All these things are now emerging, so these can also be an important MCQ. Okay, you need to know about the current variant that is going on, and all the variant and how they are like what is the use and how they are being treated and how they vary from each other. So that is going to be an important MCQ. Okay, so other than this COVID related management, okay, what are the emergency drugs that they are usually giving? All this you can expect in medicine paper as well. Okay, so viral infection has to be thoroughly read. Okay, I'm again emphasizing on the oral manifestation. Okay, as such we don't find soreness and gingivitis. Okay, some patient also developed gingivitis and some opportunistic fungal infection, okay, in the oral cavity, so that has to be studied. And other than this, mucormycosis, a very important topic, which is an opportunistic fungus that is present along with the COVID related conditions. So once you find a patient, so mucormycosis, basically it's a disease which begins, so you see a lot of manifestation in the head and neck region, so that is why it's of more concern here. So mucormycosis, you have to go in and study about everything. Okay, how what is the pathogenesis and what these organisms depend on. They basically depend on the ferrous, that is iron. Okay, they depend on the iron, and only when they take up the nutrition from them, they can grow and they destroy the tissues. Okay, so what is the important common classification of mucormycosis? Very important, and rhinocerebral type is the most common thing. Okay, I think with this we can stop with the infections. So in between we can also revise the other lesions like development also, because development was the very first topic which we saw. So we can also go and look upon, revise again on the development topic, because it's obviously going to give you more marks in the exam. Okay. So we are left now with the forensic odontology. So forensic odontology, because you need to know everything about the identification of the human remains, can be a MCQ, and other than that, sex predilection, everything can be a 1 mark question. Okay. So we are just left with the forensic odontology now, and okay, almost okay. We can take a 10 minutes break. We can take a 10 minutes break, okay, from now, and we can come back for the forensic odontology session, because it's going to be again dry, and a lot of concepts is there in forensic odontology. Okay, so I think we can stop here, have a 10 minutes break, come back, finish forensic odontology, and we will revise all the headings of every topic and leave those. Okay, we'll go on for a 10 minutes break. Okay, hope you're all back for the session. Okay, we just finished with the salivary gland lesion, and now we just saw a small recap about the fungal infection and all the recent concepts you should be knowing to answer the COVID related questions. And now we will be seeing about the forensic odontology. So that is going to be the last and final topic. So in forensic odontology, so we will be seeing about the palatal rugae pattern, about the sex determination, about the age estimation, everything about the identifying a person. Okay, so forensic odontology basically deals with the identification of an individual. Okay, so you need not worry much about the full details of the forensic odontology thing, but you should mandatorily know the important terms and conditions through which you find the age of the patient and sex of the patient. Okay, there are many interesting topics under this. So forensic odontology basically play a role in the estimation of age and sex. Okay, and also it also identify the person with more specification if they have some denture based thing, or they have some dental findings in them. It is even more important, and if they have their previous dental records, we can combine both and come to a conclusion which person has been deceased. Okay, so to find any deceased person, the dental and the dental findings as well as the findings of the cranium and the jaw region plays an important role. So with these special features, we can identify the age and the sex of an individual. Okay. So we will first deal with the sex determination. So for the sex determination, you will have odontometric methods and orthometric methods. Odontometric methods are nothing but with the help of the numbering system. Okay, you measure the features that are present in a deceased person and compare them with the antemortem records and compare their past records and come to a conclusion. Okay, it is a measurable determination method. And kiloscopy, all rugoscopy, labeling of dental process, all these are just observation related things. Okay, they just see the features present in the deceased person and compare them with that of the other records. Okay, then finally the extraction of DNA, bar bodies, okay, F bodies, Y gene and amal gene. Okay, all these bar bodies, F bodies are very specific for some gender. Okay, bar bodies are very specific for the female gender. So with this you can identify the deceased person whether they are a female or a male. Okay, so hard tissue examination. Okay, basically the mesiodistal dimension of the tooth can be an important measure in identifying the sex of the patient. Okay, and mean canine distance and morphology of the skull. Okay, all these are interrelated, and the morphology of the skull and the frontal sinus dimensions are very important. With this distinct, some patients will have a distinct bone morphology, distinct cranial morphology. So with this morphological thing, you can identify the age or sex of the patient, and also with the dimensions, you can identify the age of the patient as well. Okay. So it's a most simple method is the mesiodistal dimension measuring method. So you can measure the tooth dimension and assess the age of the patient, and the sex of the patient can also be measured. Okay. Some patients will also show canine size is going to be the male population will have a distinctive canine variation, and the males usually have a bigger sized tooth. So with that, you can come to a conclusion whether the disease is a male or a female. Okay. So this is this index is like you can use this mean canine index to come to a conclusion of the sex of the patient. Okay, it has a formula. You can take the measurement of the canine and apply in this formula and come to a conclusion whether it's a male or a female patient. Okay. So other than that, you can find distinctive tooth morphology like distal accessory ridge and cusp in the molar tooth, and all these are sometimes it is very very specific for some ethnic groups. Okay, some ethnic groups might show this proper distal accessory ridge and extra cusp. Okay, and some even male and female population can also show this different extra distinct tooth morphology. With these tooth morphology, you can find some relation to the sex of the patient. So females exhibit lesser number of cusp in the mandibular first molar when compared to that of the male. So with that you can identify, and distal accessory cusp is more pronounced in the male patient. So these two can also be used. Okay. So morphology of the skull. So skull, how the zygomatic bone is present, and the males will have even more pronounced jaw bones when compared to the female patient. So with all that, some even the gonian angle, the that is the elevation and the depression that is seen in the mandible, and also the sharper facial structure can be more pronounced in case of the male population. But in the female population, the mandible size is going to be more smooth and rounder, or more round appearance in the face is more commonly seen in the female patient. So with these architectural changes, also you can come to a conclusion of the patient's sex. Okay. So more greater mean values of the frontal sinus and more width and area in case of male. Is also seen in the frontal sinus dimension. Okay. Okay, then moving on to the chiloscopy. Chiloscopy is nothing but the pattern that is present in the lips. Okay, whenever you take the print of the lip, you find some distinct characters, distinct lines or patterns that is present, which is distinct for each human being. Okay, so this is actually not more standardized, but still you can find to some extent if you have the previous records. Okay, so there are types given for these chiloscopy, that is prominent. Type 1 is more seen in female. Okay, you can see the picture in the type 1, so it is seen more common in female. Type 1 and type 2 patterns are common in females. Type 3 pattern is more common in male, and type 5 is also more common in male. Okay, these patterns, with this you can just identify the sex of the patient. It is sometimes more distinct for some of the patients. Okay, but with this you cannot conclude because the standardization is still not proper. Okay, so moving on to the bar body. Bar body is nothing but an extra structure, that is, it is a condensed chromosome that is seen only in the female nucleus. Okay, nucleus of the humans. Okay, they show some condensed chromosome, which is an inactivated chromosome. It can also be identified as an inactivated chromosome which is present. Okay, this is the bar body which is present in the nucleus of the female alone. Okay, when you find a bar body in the nucleus of a patient who is deceased, then you can come to a conclusion that she could be that the patient could be more of a female patient. Okay, then moving on to ML gene. So amylogenin gene, this particular gene can be present both in the females and male. X gene is seen in the female and Y gene is seen in the male. Okay, females have two identical amylex gene. Okay, so this gene can also be used in the identifying whether the patient is a male or a female. Then palatal rugae, we all know that it is going to be the lines which is elevated muscular structures which is seen in the palatal region, anterior palate. Okay, these lines have some distinctive pattern. By tracing these patterns with the help of the cast, you can find the patient, identify the patient as it. Okay, some patient have a distinctive palatal rugae, and some female and male patterns can also be given in this palatal rugae. Okay, so when we started, we just started with the mesiodistal dimension, then we went on to the distinctive tooth morphology, then we went on to the skull and the mandible structures, then we went on into the chiloscopy. Okay, then bar bodies and the genes related. Okay, so these are the some factors through which you can identify the sex of the patient and age of the patient. Okay, so that's all about the forensic odontology. Okay, other than that, you can also refer the classification systems for the palatal rugae and classification systems for the palatal rugae and kiloscopy. Okay, there are few classification systems that you should be knowing. You can refer Schaeffer's textbook for this because they have detailedly given all the forensic odontology topics, and you can also find the specimens through which how they come to a conclusion. So the cast, making the cast or the replica of the patient's oral cavity can give n number of features to identify the particular individual. Okay. So we will just brush through the topics that we have seen today. Okay. So we just started with the developmental disturbances. Okay, developmental disturbances. I told you about the picture-based questions and those questions associated with fusion, gemination, concrescence. Okay, so these topics has to be thoroughly read, and we went on to identifying the syndromes. Okay, syndromes. There are a list of syndromes. Okay. These syndromes you have to take a note of. Basically, the Peary-Robinson syndrome, the anomaly, Peary-Robinson anomaly. So it is a condition of three distinctive condition. Okay. So the cleft lip and cleft palate patient, how it is happening? Because in Peary-Robinson syndrome, the patient jaw is smaller in size. Okay. Because of the smaller size of the jaw, the patient's tongue is unable to lodge itself within the jaw region. So it is going to stay back in its position near the palate. So it is going to obstruct the palatal shelves from closing from either side. Okay. So this tongue, since it is obstructing, there is going to be a defect in the palate. Okay. And why this defect in the palate is occurring? Because the tongue is not descending downwards to its position. Why it is not descending downwards to its position? Because the tongue is unable to accommodate itself within the smaller size of the jaw. So it is a triad. Okay. So the triad basically involves a smaller sized mandible, a bigger sized tongue, and a cleft that is present in the palate. Okay. Because of the tongue that is obstructing the palatal fusion, it is going to have a cleft lip on cleft palate. Okay. So cleft palate, all the three is going to contribute to the Peary-Robinson anomaly. Okay. So similarly, we saw about Down syndrome, then Treacher-Collins syndrome. All these syndromes are very important. Then we went on seeing about the cysts and tumors of the oral cavity. Okay, odontogenic cyst and tumor, and we saw some examples in each. Then we went on seeing about the epithelial pathology, wherein we saw the viral-related conditions and other, like in leukoplegia and oral submucous fibrosis and squamous cell carcinoma. Okay. Then we went on seeing about the important distinctive condition called as Varicose Carcinoma. As I said earlier, it is common in female. Okay. It's a proliferative lesion. It can be a multiple lesion with a distinctive clinical histopathological appearance. Okay. Then we saw malignant melanoma and how to describe malignant melanoma in the basis of symmetry, border, then diameter and evolving. Okay. Then we went on seeing about the connective tissue disorders. Okay. Then dental caries. Okay. Dental caries, everybody would be knowing about the theories. It's very important. Then we went on knowing about the Riemann-Demon cycle. It's very important even to know because it is also overlapping along with the conservative. Okay. So anything and everything about dental caries will overlap with conservative. So when you study this particular topic, you just have in mind that you're going to answer both conservative as well as a oral pathology question. Okay. Then the recent trends. Okay, recent trends, you have to know what are the recently added things: attitude, education, behavior, socioeconomic status, income. Okay. And also when there is a demineralization, when you add a mineral like calcium or phosphate and fluoride to the demineralized structure, it is obviously going to remineralize. Okay. Then pulp and periapical diseases, we saw about osteomyelitis. Then we went on to infections. So infections we already brushed through. Okay. So I'm skipping infections. So anything about COVID and mucormycosis is going to be important question. And Why rhinosporidiosis here? Because rhinosporidiosis has been taken off from the fungal infection and it has now been added to a parasitic infection. It is caused by Rhinosporidium seaveri. Okay, any nasal polyp which is present in the form of a strawberry shaped or strawberry stuck surface. Okay, you should think in terms of rhinosporidiosis, and the distinct histopathological feature which we saw with the sporangia. Then we went on to the viral infections. So viral infections, I told about herpes and varicella zoster and other things. Even HIV manifestation is also important. Oral manifestations of HIV can also be asked as an important 1-mark question. Then we went on to bone. In bone, we have to know about the fibroosseous lesion, and I told that the periapical, focal, and florid osseous dysplasia. There has been many questions, so obviously you have to learn about the three. Okay, focal in the anterior region, florid, periapical, and florid is going to be the generalized condition. Then we went on studying about fibrous dysplasia. Okay, it's a massive lesion which is formed due to the mutation of GNAS gene. Okay, then we saw about the monostotic and polyostotic fibrous dysplasia. Okay, then about the café spot. Why do we see multiple presentation in this particular condition? Because this particular gene which is mutated is responsible for the development of bone, then endocrine system, and also it has an effect on the melanocytes. So because of all these, you find a varied appearance. Okay, then moving on to the Shepherd's crook deformity, which is the fibrous dysplasia seen in the long bones. So moving on to the histopathology, which is the defective bone, which is seen in the Chinese letter pattern. Okay. Okay, which is a Chinese letter pattern, and also then you go on to the cemento-osseous dysplasia. Okay, so in this, the 3 stages. Okay, the focal is going to be anterior, and the periapical is going to be in the single tooth, and the florid is going to be multiple tooth. Okay, then we went on studying about the genes that is defective in the cemento-osseous dysplasia. Then focal cemento-osseous dysplasia is seen in the molar region. So the stage is very important: osteolytic stage, or cementoblastic stage, and maturative stage. Okay, then periapical, the similar stages. Okay, in the osteolytic stage, there's a radiolucent lesion. Then there is a mixed lesion in which you cannot differentiate whether it's an osteolytic or osteoblastic. Okay, whether it's radiolucent or radiopaque. Then the maturative stage is completely radiopaque stage. Okay, then periapical cemento-osseous dysplasia is seen in the anterior region. Then florid, okay, it is seen everywhere, okay, throughout the mandibular jaw. So I also told an important point that this is more common in the African woman. Okay, so macroscopic feature, and you see cementum like structures in the histopathological lesion. Then we went on doing the blood dyscariasis, wherein we saw the general features of hemoglobin drop and the RBC defects. We went on studying about the anemia, its clinical features. Okay, then investigation of anemia is a very important thing. You should know how you estimate the anemic condition and what are the tests you have to do when you have to come to a conclusion of anemia. Then the abnormalities in the blood, peripheral blood smear, okay, anisocytosis, poikilocytosis, hypochromasia, and polychromasia, and Howell Jolly bodies. Okay, then we went on studying about the different shapes of the RBC. Okay, then investigations for anemia. Then we saw about iron deficiency anemia, iron metabolism. Whenever there is a reduced amount of iron intake, we come across iron deficiency anemia, and whenever there is going to be proper intake, but the absorption is abnormal, then also we have experienced iron deficiency anemia. Okay, then absorption, it is usually happening in the duodenum and the proximal jejunum. So pathogenesis. So whenever you experience anemia, the available ferritin, okay, the storage form of iron is also exhausted. So the patient will result in the iron deficiency. Okay. So common epithelial changes. So very important, oral change is very important for us. Basically the atrophic glossitis and angular cheilitis. Then we went on studying about the oral manifestations, similar thing, and we went on studying about the blood picture. Then biochemical changes. Here the iron level is usually low, even the storage form of iron is also low. Okay. Then the difference between the cells, then treatment. So Plummer-Wilson syndrome is very important because it is basically begins as an iron deficiency anemia, then it goes on to formation of esophageal web and patient develops dysphagia. So women in the age of 40 to 70 years more common. Okay, iron supplements are usually given to correct the condition. We went on studying about the skin lesions. So Lichen Planus is very important. It's an autoimmune condition. So there is a disruption in the basal cells. Okay, this is subbasilar cleft. Then the basal cells are being disrupted because of the autoantibody that is formed against the basal cell, and the basal cell undergoes apoptosis. So 9 P's of Lichen Planus. Then we went to the clinical features and types of Lichen Planus. Then Pemphigus. In Pemphigus, what I told, it's going to be the defect in the desmoglein 1 or 3, because of which you will have a suprabasilar cleft. Okay. So in this, I explained you about this is the suprabasilar cleft is usually seen in this layer, which is seen in the Pemphigus, and in the subbasilar cleft, which is seen because of the defective basal cell, which is the condition seen in the Lichen Planus. Okay, then we went on studying about the salivary gland tissues. Okay, the normal morphology, you should know about all the cells that contribute to the salivary gland, mucous cells, serous cells, and the ducts which contribute to the salivary gland, intercalated, striated, and the excretory duct. And finally, I told about the basket cells, that is the myoepithelial cell, which has the contractile ability, which will pump the saliva into the ducts. Okay. Then histogenic concept, which will tell you which cell will help in the origin of the tumor, and morphological concept, which is going to contribute to the major part of the tumor. Okay. Then we went on to the classification. Then we studied about MEC, okay, which is a common salivary gland tumor. Okay, then we went on studying about the cells that are present, mucous cells, intermediate cell, then the epidermoid cell. Finally, we went on seeing the clear cell and the grading of MEC, okay, low grade, intermediate grade, and high grade. Finally, we saw the FNAC findings, because for any salivary gland tumor, it's very important to know the FNAC findings, because it is going to show the secretions of that particular tumor. Then the grading system of different systems. Then we went on to Gliomorphic adenoma, which is another common salivary gland tumor. It's a mixed tumor and it's called by various names. And the etiology because of the changes in the PLAG1 gene. Okay. Then the clinical features, unilateral lesions seen in the major salivary gland. Then we went on seeing the cell population, that is the ductal and the myoepithelial cell, along with the stroma, which shows chondromyxoid changes. These are the other features. Okay, spindle shaped cells, many cellate shaped cells are also seen. Okay, these are the various representations of the histopathological features of pleomorphic adenoma. Then we finally concluded by saying that pleomorphic adenoma will also have some malignant changes. Then we went on to forensic odontology. Okay, in forensic odontology, we saw all the. In forensic odontology, we saw all the identification procedures, like for identifying the sex of the patient, age of the patient, and everything. And we went on seeing about the age estimation and what are the sex determination procedures. So the hard tissue examination and the soft tissue examination were included. And we saw the mesiodistal dimension can be used as an important feature in identifying the sex of the patient. So also the distinct tooth morphology like distal accessory cusp and females having less number of mandibular cusp, okay, when compared to males. Then the skull based features for male and female. And finally, we went on seeing the frontal sinus dimensions to identify whether the patient is a male or female. Then cheloscopy is a soft tissue examination wherein you can see dominant patterns in case of males and females. Okay. Then bar body identification. Okay, bar body is a condensed chromosome which is usually in the nucleus of the female patients. Okay. And AMEL gene, so distinctive for female and male, X and Y gene. So there is a 2 identical gene for females and 1 for the male. And we went on studying about the palatal rugae. Okay, we take the cast of the patient, trace the palatal rugae pattern and compare them with that of the previous records of the patient to identify the patient. And also these patterns will be more specific to the male and the female patients. Okay. Thank you so much. I hope you all had a good session. Okay. I think we have covered a lot of things today. Okay, I know it's very vast. Oral pathology is always vast. Okay, but I hope you take a little amount of knowledge from this class. Okay, do not panic. The exam is nearing. Okay, I know that you have still more time for this. You can take a good rest every day and concentrate on topics which is very important. Concentrate on those topics which will give you more marks. Okay. And also oral pathology is one subject. When you study oral pathology, you can answer n number of questions. So consider studying oral pathology in the first because it's vast also. Once you finish oral pathology, you can easily finish all the other clinical subjects. Okay. I hope you had a very good session. Thank you so much. Thank you so much for the team for giving me this opportunity. All the best for your exams. I hope you will come out with bright colors. Thank you.
Thank you, Doc. Nice efforts. I think we have a student. If there is any clarification.
Yes, sir.
Is there any doubts? Dr. Vibha, are you there? Can Dr. Vibha be unmuted? Yes. Dr. Vibha, are you there?
Yes, sir. Yes, sir.
Yeah. Any clarifications, ma'am?
Sir, how could I know that which topic will give me more marks?
Okay. Can I go and answer, sir?
Yes, ma'am, please.
Actually, there is hello, Dr. Vibha. There is a split up for every question. Okay, you can like it will be changing. The pattern will be out soon. Okay, as of now, 14 marks is given for every subject. Okay. So whenever you study a like 14 marks for a single subject, okay, so you have to take a note of this separation. Okay, you can go find them in Google also. Okay, there are a lot of website they are giving the split up for each thing. Okay, the proper split up will be given by the government before exams. Okay, but as of now it is 14 marks for each subject. Okay, so every subject will have an equal split up for that, but it might change when you answer the question. You will find some difference. Some question will be more from some subject, because when I attended NEET, I had a lot of questions from the general medicine and general pathology side. Okay, so it might differ. Okay, but as of now it is 14 marks for each subject.
Okay, ma'am. Thank you.
Dr. Vibha, just to add on to it, see, though it is told that we have 14 in per subject and all, but then we have a lot of gray lines. You never know a question is from general medicine or oral medicine or oral pathology.
Yes, yes, sir.
Okay, so what madam was trying to tell is what is legally there printed on the brochure, but then that's the overall split up. But then the lines are always very gray, doctor. So I would say, if you ask me this, where should I give a weightage on? Well, it's very difficult for me to answer. Okay.
Okay, sir. Thank you.
Thank you. And you want to have any, I mean, this format of class is okay with you, or would you like to have any suggestions from your end?
Sorry, sir.
If you have any suggestions of the format of class or something like that, you can just drop us a mail or send the feedback, or send it to the WhatsApp to the admin number. We should be able to address your whatever queries you have. Okay.
Okay, sir.
And if there is any specific doubts in this class, I'm sure doctor will be there to answer you.
No, sir. Thank you.
Fine. Thank you. Thanks, Dr. Ramya. I think you did a fabulous job today.
Thank you, ma'am.
Thank you. Thank you.
We have a lot of people watching on you on live YouTube live. So if there is any queries from there, probably I'll just reach you through Dr. Lakshmi.
Oh, yes, sir.
Thank you. And if the session is done for the day, I think we'll finish it off. And please do join us for the class tomorrow on oral medicine at 9 o'clock. Lakshmi, is there anything else to add, doctor? Yeah, I think thank you. We'll just finish off the day. Thank you for everyone. Thank you, Team Speed, for the excellent coordination. And we'll meet you tomorrow 9 o'clock for oral medicine. Thank you.
Thank you, sir. Thank you, sir.